Nobody wants to talk about the S word. It's a bad word, right? But it's one of those things that nobody believes in. It goes, happens how it happens kind of thing. But I think that we need to normalize and standardize that it's part of our assessment with every patient that we have. We need to ask. If you look at guidelines, if you look at recommendations about which screening tool is better than the other, they're all good. There's a reason why they exist, right? The specificity, the validity of these tools is there. So they all work. It's all about how you use it and how you implement it. So a lot of these tools are not going to tell you if that person it's not going to diagnose this person, oh, this person's having SI or whatever. But it will tell you that this person is like, it'll give you the red flags.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement because we all know emergency nurses have the best stories. Now, here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing, and thank you as always for downloading this episode and listening to the podcast. I think I don't remind you enough that this isn't the only podcast I do. I also have another podcast that I do with Dr. Lisa Wolf called How Not to Kill Your Patient. That podcast is a little bit more clinical, and we cover a variety of clinical topics stemming mostly from triage. But if you like this podcast, you're going to love that one too. I also want to take a second and remind you that one of the best things you can do to help the podcast out is to leave a rating and review in your podcast player of choice. So if you're listening on Apple Podcasts, get on the system and leave a rating and review for this podcast. It's a great way to help the show out, and it helps more people like you find this podcast. My guest today is a pretty amazing nurse. Not only is he a longtime paramedic, longtime ER nurse, but he's also a family nurse practitioner and a psychiatric nurse practitioner. We had an amazing conversation not only about his experience, but also about dealing with psychiatric patients in the emergency department. You are going to love this episode with my friend, Dr. Aaron Salinas.
So my name is Dr. Aaron Salinas. I am a board certified family nurse practitioner and psychiatric nurse practitioner. I am from the Rio Grande Valley. For those of you guys that don't know, I'm at the southernmost tip of Texas, where we connect to Mexico. I've lived here all my life, and currently I'm on the state Texas Emergency Nurses Association. I'm on the state board, and my role is a director.
Awesome. So you did both family nurse practitioner and psych nurse practitioner. Why'd you do both?
I did. So when I was going to school, I had the opportunity to be part of the very first psychiatric nurse practitioner program. And when I did EMS before becoming a nurse, when I worked in the ED, the hospital I worked at, we dealt a lot with mental health issues, a lot of psych patients. And there was a lot of things that I just didn't agree with on how we dealt with these folks in the ED. So I already had that spark. I already had that interest, right? And when the opportunity came up to be a part of this program, it was the very first program. And it was pretty much going to be a free ride to complete this program. And I went ahead and took it. So once I took it, I was like, well, I'm kind of limited with just the mental health part. So I decided to go back and become a family nurse practitioner. So yeah, that's
Good for you. That's awesome. Yeah, I always say that when you get into the nurse practitioner realm, like there's family nurse practitioner, there's acute care, and there seems to be psych seems to be kind of emerging, and it seems to be a pretty good field to get into right now. Would you agree, or
right. So when now we're seeing 1 every 4, 1 every 5, people have a mental illness. Really depends on what resource you use, but that's severe, man. So it's important that we continue to, train mental health providers, and we have a lot of gaps. And I'm not saying that time wise we'll be able to keep with the immediate demand, but we can surely try and work towards getting as close to it as possible. And I think that's really where a lot of our focus should be in the realm of mental health. We need to continue training mental health providers, and we need more folks to get involved or start taking care of patients that have mental health issues. And that's the only way we'll really get anywhere as far as addressing the needs.
certainly there seems to be a lot of mental health needs, and I think the audience, the ER nurses in the audience know that probably better than anyone. Like,
Oh, yeah, for sure.
I don't know. I remember in one community I worked in, like we would have psych patients sit in the ED for days waiting for
Right.
placement.
Right. That's a huge problem. I just had a conversation about that with someone yesterday. We were talking about inpatient hospitals and I attended a mental health law symposium a couple of months ago, and and you had these experts, these judges that everyone, their expertise is mental health. It was interesting to hear that a lot of the folks that are incarcerated and things like that, like they went into how they're addressing their mental health needs and things like that. But one of the things that really stood out to me is a lot of our focus is on inpatient hospitals, and it shouldn't be, you know what I mean? Because a lot of these folks can be very much treated in an outpatient hospital. So the challenge that we have as in the emergency department is that we're trying to find a placement for them. And a lot of times we're not able to. So they'll stay in the ED, they'll board in the ED for a few days. A lot of times they don't even make it to the ED. They'll be there for 3, 4 days, being evaluated every 24 hours. And sometimes they'll just discharge them. They'll do their evaluation. They'll see that they're doing well and they'll let them go home or whatever the case may be. So it's a big challenge. Our hospitals our EDs are full. COVID, influenza, all these other things that are going on. And then we'll have other folks that have mental health issues that are, helping keep the EDs even busier or fuller. It's a big challenge.
Yeah, for sure. And now, is there like a pay difference between the acute care practitioners, the family nurse practitioners, and nurse practitioners? Is the pay pretty comparable, or does one kind of outweigh the other?
No, I guess it really depends. It really depends. I know family nurse practitioners, their problem is a lower to like acute care. Yeah, my response to that would be it's more on the specialty. Mental health, I can tell you, is paid very well.
Yeah.
But also the demand is bigger. Their cases are a lot more complex. They're not very, straightforward compared to family medicine. So yeah, it's I would say it's on based on specialty.
Yeah. What made you decide to become a nurse?
Actually, that's an interesting story. I never wanted to be a nurse. So when I to be honest with you, I never wanted to do anything in healthcare. When I was a young man, we used to go work up in West Texas, and we used to work in the cornfields during the summer. So we were migrant workers, and I always wanted to be a farmer. That's what I always wanted to do. So when I was 13 years old, my dad passed away, and he had a stroke. When that happened, I never wanted to know anything about healthcare or anything like that. Right. So when I was in high school, one of my good friends, his father owned an ambulance company, and we graduated and we needed a job or whatever. So he sponsored us for the emergency care attendant program. And that's really how it started. I was an ECA. After I became an ECA, I became an EMT basic, and I was interested in the physician assistant program. So at that time, it was a baccalaureate program, and I thought I was ready to apply. So when I came to meet with them, they had made some changes in the shadowing hours.
Yeah.
So I wasn't writing, I was missing 20 some hours, and the program director at the time was like, "You should consider nursing." I was like, "Well, I don't know about that." So I applied, and my grades weren't that spectacular, and I got in. And the first semester I was miserable. I hated it. But then after that, I had an interesting experience with a patient, and the rest is history. Here I am now.
That's awesome.
Yeah.
Uh, any regrets?
No, no way. Things have been well. Been a lot of work. I work more now than ever before, but I love it. I enjoy it. I enjoy what I do. I get to People trust me with their lives, and I get to them get better. That's pretty neat.
That's very cool. That's very cool. So how long did you work in the ED? Did you work so you worked ED for a while as a nurse?
So I was there for about 8 years.
Okay, that's a long time.
Yeah, I was there for about 8 years. And after that, I stayed doing EMS. So to be honest with you, I stopped working EMS, like being on the trucks 2019.
Oh,
Yeah, I was already a nurse practitioner, but they would use me for the football games and stuff like that. And I always had stuff. People said I was the black cloud. I always had things happen at games and stuff like that, but I enjoyed it. You know what I mean? Yeah, I enjoyed it. I think that's something like now that I did a publication with a couple of EMS folks. I think that's really where I want to continue to get involved with EMS in the realm of mental health. And I know that some of our local EMS providers are doing the whole, what is it, the community paramedic and that kind of thing. So
yeah.
So I'm hoping to help them with the mental health aspect of it. So I miss it, man. That's really where my heart is, EMS and actual emergency room nursing. But
So for people who don't know what the community paramedic's all about, can you tell them just briefly what it's all about? And I'm kind of putting you on the spot right now. So
Yeah, no, no worries, no worries. So just like there's different types of, like, you have your critical care paramedic that's focused like on critical care skills, those kinds of things. There now we have a community paramedic. So the community paramedic, when you think about like a home health nurse, but obviously they're a paramedic. So what they do is, it's the paramedic that will go do like a round at visit someone, more like a wellness type of visit. So they might do blood pressure checks. They'll do like a glucose checks. They'll make sure they're taking their meds, that kind of thing. A lot of their focus is on promotion, wellness, those kinds of things. So I know in our area and the Rio Grande Valley, it's become very popular, and it's good because hospitals love it, because these are folks that I hate to use the term frequent flyers, but these are patients that, and I know that the companies down here are focusing on CHF. And so these are folks that, for example, kept going to the hospital for the same things. But they're having someone monitor them, because a lot of times you can't afford a home health nurse or whatever. So it'll be a little more cost effective to send a medic, and their medics are excellent at what they do as far as assessing, as far as educating folks and stuff like that. So yeah, that's the new trend. And I have a feeling that it'll continue to grow.
yeah, I
The-
think it's gonna be a bigger and bigger deal.
oh yeah, for sure. For sure.
So, and then you said you kind of got into psych because one, it was available. But were there any kind of particular patients, like, in psych that made you think, "Okay, like, this might be something I can really kinda dive into and something I can work on?" Did you have a particular passion for psych patients or?
Oh, so I enjoy it, because a lot of times I was not a fan of how we dealt with folks that had mental health issues in the ED. A lot of times, and I know most of the folks that will be listening to the podcast will really understand. A lot of times they just need a sandwich, Gatorade, those kinds of things, and the way we come across them being aggressive or demanding or whatever that might be a trigger, or things might escalate. And there's no need for that. You know what I mean? And that's the biggest reason that I decided to pursue it, because I wanted to be a voice for these folks. They're the same as just as you and I, you know what I mean? And there's a lot of stigma that in the realm of mental health, that mental health doesn't discriminate anyone. You could be rich, you could be poor, you could be a doctor, you could be a judge, whoever, you know what I mean? And I've had a lot of scenarios that should not have gone the way they did. So that is the reason why I decided to pursue that, because I wanted to be the voice. I wanted to be able to treat these folks as humane as possible.
Absolutely. Absolutely. I think psych patients are you always have your couple nurses who are kind of the psych whisperers, like, they just do
Right, right.
great with psych, and then you
I
have
was
other
one of
people
them.
and you have other people that just aren't good with psych at all, and they're just like,
Right,
I'm just gonna turn this patient over to someone else because I can't work with these patients well." And while it's important to know your limits, like,
right.
almost every patient has some degree of psych somewhere in there somewhere,
That's right.
right?
That's right.
And even if they don't have psych, just the general principles of communication that you learn from taking care of psych patients is critical for every damn patient that we touch.
I agree.
So yeah, I think people don't necessarily always remember that. So
Yeah, I agree. Agree.
tell me about a patient that changed the way you practice, someone that you look back and you're like going, okay, this was a kind of a key patient for me.
Well, so it's changed my practice in general. Okay, so I shared with you my first semester of nursing school, and this is a story that I've shared a couple of times recently. So I'll never forget. I was coming off shift, and it was a Sunday coming into Monday. I had Monday class. I was in my first semester of nursing school. I mentioned I was miserable. I hated it because I wanted to be a physician assistant. I didn't want to be a nurse. So I ended up going to McAllen Medical Center. And when I get there, it was about to be change of shift for them. We were an early 6 o'clock truck. So they changed shift at 7. So we arrive, and I'll never forget, Dr. Ray is one of the old school McAllen Medical ER docs, was like, "Hey man, you got to get this patient to the comfort house and terminal, just get there. We have a DNR, that kind of thing. If the patient crashes, don't come back." That was the talk, right? So I go inside, and I'm greeted by the nurse, and his name was Al, exact same message, right? You know, that just hurry up and get there. Don't be surprised if the patient arrests on the way over there. And to be honest with you, the comfort house was a couple of minutes away from the Cal Medical Center. So we get there and patients in trauma 2B, I'll never forget. So me and my partner, we go in there and both patients are sitting up and talking. So I look at him and I'm like, dude, is this our patient? So we start talking to him and that's our patient, right? So we transfer him over to our stretcher and my partner was already upset and we were already going over our time on our shift and blah, blah, blah. So I'm like, dude, it is what it is, right? Or whatever. So we get into the unit and he wanted to take off. And I said, no, don't take off. Give me a minute. Let me get started on my paperwork because I have class like as soon as we get out of here or whatever. So I'm talking to the patient and I was in a bad mood. I had an exam. I hadn't studied. We had been up all night with calls in McAllen, that kind of thing, right? And he tells me, and I was already working on my documentation. And he's, see, you got problems. And I'll never forget that. And he looks at me and I look at him and they say I'm dying. And that captured my attention. Just hearing him say that. So I put my laptop down and I started talking to him. I'm like, well, he had cancer. And I'm like, well, why are you alone? That's my first question, right? And he's like, I have a family. He has a wife. They live in San Juan, which is a nearby town. I have a daughter, I have a son. And he goes on to brag about him. When he was talking about him, you could see his spark. You can see he was so happy to talk about his family and those kinds of things or whatever. And I was listening to everything he was saying. And so we take off, right? And we get there. And he was so happy. And for a second, I would have never thought that he was the man, that patient I was transferring that was about to look to the ENP doc and the nurse who we were expecting to pass because he was as lively as you and I conversing and all these other things, right? So we get there and the door wasn't open. So I told my partner, just go around the block. It's because I could see how engaged he was and how he was enjoying being in the moment or whatever. So then we finally come back we go around the block. We arrive at the comfort house and we go inside, right? We go into I'll never forget. It was the room in the middle. We would take our stretcher. We get in the middle. He had a cell phone, and I asked him, "Do you want your cell phone?" And he's, "No, I don't." "Can you give me the Bible?" So I give him the Bible, and as we're getting ready to leave, he looks at me and he tells me, "Thank you." And I'm like, "Thank me for what?" And he's just, "Thank you for listening." And so I come back. To the unit. So by this point, okay, I mentioned I had an exam. I'm supposed to have an exam that morning. I'm tired. We had been up all night, and I was like, okay, you know what? I think a lot of other folks would have not wanted to have that call or that transfer right before the shift is over. But you know what? And here I am being selfish, complaining about an exam or whatever, where this man is about to die.
Yeah.
And yet when he was speaking to me about his family, about his loved ones, that a lot of things were put into perspective for me.
That's the shit that matters.
Yeah. And he thanked me. I didn't do anything special. All I did was treat him like with respect. I listened to him. I heard him out. I put my laptop down. I gave him my contact, put my arm on his shoulder. I treated him as we all should to any one of our loved ones. And I'll be very honest with you. And he gave me this talk because I told him I was tired. And he gave me this whole, like, you're going to sleep when you die kind of thing is really where he said. And I was like, wow, like,
Yeah.
okay. So to be honest,
easy for you to say you're dying here.
yeah, that's what I thought. That's exactly what I thought. But you know what, man? Yeah, that's been one of the craziest experiences I've ever had. So when people ask me, how do you do what you do? How do you keep up with it? I've learned to not complain and just get it done. And he's always in the back of my mind and in my heart because that's an experience I'll never forget.
Yeah,
I can see his eyes. I can see how he looked at me. And you know what I mean? And I would want that for any one of us to have someone to, especially as you're sick, as you're ill, even if as you're passing or whatever the case may be, to treat someone with respect and compassion. And to me, that was a life-changing experience. So I could be having the worst day ever in clinic, but you know what? I'm going to give everything I can to patients, make sure that they know they're there for the right reason, because I love them, I care about them, and I want them to do well. And yeah, I've never looked back after that, and I've changed my attitude, and things have been well, to be honest with you, for everything.
Well, man, it's crazy how those patients that seem just kind of routine, can just kind of touch your heart and like never
Yeah. No, it
completely change the way you do what you do.
right, right. And it was that moment that I'll never forget. I came back and my attitude really changed and I learned to embrace what it is and just go with it. And after that, the nursing program was very challenging because I worked a lot. I was still very active with EMS. I worked full-time weekends and at that time I was a basic. So I was doing my nursing program Monday through Friday, 8 to 5, and then I did my paramedic at night. So
Wow.
that was intense. And I worked the weekends, Saturday and Sunday.
Do you
So that
maintain
was
your paramedic license too still?
I do. Yeah, I do not. I'm
Good
still
for
national
you.
registered. I'm still national registered.
Good for you. That's
Yes,
awesome.
sir.
I had my EMT intermediate for years. I started as an EMT. I had my EMT intermediate for years and I never did the paramedic and I always regretted it.
Yeah.
And I regret it because I would love, and yeah, not that I have time to do it right now, but I would love to do some EMS work, like volunteer.
Yeah. So I jumped on the call. My friends from Willacy County, we were at an event and they were so Raymondville and Port Mansfield. Port Mansfield's about what maybe 45 minutes or whatever. So they had a unit out there, and by the time you get fire department or you get backup out there, it'll be a while. So something happened. I think it was a slip and fall. So I got to jump on the trucks with them and the third man kind of thing, and it was yeah, it felt right, and I miss it. And
You were like Dr. Salinas, a nurse, paramedic,
I was meeting. I'm constantly being invited. I keep up with these guys here in the valley, and they always have my support. Whether I do a lot of advocacy and policy stuff at the state level and the national level, I always keep them. That's where my heart is, man. I support these guys, and I'm always being invited. Hey, just come on, do a ride out with us. And so I'll probably follow up with them soon, probably during the summer when I got a little bit of time. But yeah, I miss it. That's where my heart is.
That's cool. That's really cool. So I want to take advantage of your expertise while I got you on here and just ask one of the things we see in the emergency department all the time. We see psych patients all the time. And I don't think everybody does a great job taking care of psych patients. So my question for you is what suggestions do you have for taking good care of psychiatric patients in the emergency department? Like what advice would you give nurses looking after these patients?
That's an excellent question. Well, the first thing we have to do is we have to change our attitude. Okay. And the reason I'm saying that is because if you think that if you're in the emergency room or in the ICU ward or on tele, you're going to come across someone that doesn't have any mental health issues or any psych issues or anything like that, you're absolutely wrong.
I mean,
That's
it's a comorbidity for like
yeah, it is.
so
It
many,
is.
right?
Yeah. And it's going to happen. It's just a matter of time. So that's the first thing we got to do. The second thing we got to do is we have to acknowledge that they're people, they're human, right? It's not the bipolar guy. It's the man that has bipolar.
Yeah.
Okay. So those are the top two things that I would say that we must really make sure that we instill it in our brain. The third thing would be that we talk to them right and treat them right. You know what I mean? A lot of times, for whatever reason, they're there, right? Whether it's something that whether it's some kind of trauma, whether it's something that because just because you have, for example, the diagnosis of bipolar or schizophrenia doesn't mean you can't live the normal life. A lot of people, some of the smartest people I know have a diagnosis of bipolar and schizophrenia. They do well, it's managed, those kinds of things. So a lot of times when they come to the EDs, when they've had an episode or they've had a trigger for those kinds of things. So we need to listen. I come across a lot of folks that they don't let them speak. A lot of times they just want to be heard. And I understand we're in the ED when people are going to say, well, we don't have time, blah, blah, blah. But yeah, you do. You got time. You got time. And if you don't have time, make time. Listen to them. What is it? Whether it's sometimes it's just taking them a sandwich or a Gatorade. You know what I mean? But a lot of the issues that I've seen where things escalate is, you know what, you need to give me a urine and you need to give me urine now, or I'm in a cath. So a lot of it has to do with that and how we communicate. I mean, we communicate and how we come across these folks. And as it is, think about it. They're already, and let's say they have schizophrenia. Let's say they're hearing voices, and then you come across them, and you're very aggressive in your tone and your approach. How do you think someone like that is going to respond or react?
Right.
It's all normal, right? So I think we need to be compassionate when we see these folks. He used a different approach. used a non-threatening approach. We're very big about restraining, and I've seen it. You can't tell me it's not true. I've seen it. I've lived it. I've been there. So that needs to change. I understand we want to get them in and out of our EDs and things like that as quickly as possible. That's our game plan for every patient, not just our patients that have mental health issues. So I think a lot of it is the balls in our court and how we approach and how we deal with these folks that are coming in when they're experiencing crisis, because majority of the time that's where they're going to come. For us in the Rio Grande Valley, we have even less resources than the rest of the state. So for many folks, this is their primary care, or this is their
100%.
psychiatric visit or whatever. So we just need to be mindful of that. And I love caseworkers, I love case managers and things like that. But that's where we need to make sure that you're just not going to discharge and get rid of them. You want to make sure that you help set them up, and whether it's with tropical, whether it's behavioral health solutions or whoever you have. And that's what I think. But we have some amazing nurses in Texas. But I think that just because you work in the ED, be real. Not every, how many of the cases that you come across in the ED are actually like severe trauma?
Yeah, not everyone.
Not everyone, but the perception that people have, that's all you're going to see: gunshots, stabbings, those kinds of things. So I think a lot of it is we just need to change our attitude and be compassionate and caring with these folks and listen. We're terrible at listening. We are. We get impatient if they're slow to speak or whatever. And these things upset them. A lot of times these folks are on the edge, and it's okay because for whatever reason, they're in our EDs. Something set them off, something triggered, whatever it is that they're experiencing at that time. So yeah, that's what I think. And the other thing is, not not every patient that's in the ED having psych issues is regressive or things. So that's one too that we need to. That's a big stigma. But we the possibility of you being hurt by any patient is always going to be there anywhere, not just patients that are having these types of issues. So
Yeah.
the bottom line is just being compassionate, be caring to these folks, be mindful that they're humans just like you and I, and work with them, not against them, because that's where we run into issues.
One of the things I tell new nurses all the time is, like, I always tell nurses have amazing BS detectors, right? Like, we're really good at reading people. We're really good at picking up BS and telling when someone's lying, telling when someone's maybe not being as truthful as maybe we'd like them to be. But one of the things I always remind nurses is like the only person who's better at that than we are is our patients.
Right.
Especially our psych patients can read you like a book. They know if they're getting on your nerves. They know if they're touching that last nerve of yours. And they know whether or not you're compassionate and kind or less than compassionate and kind. And they read it so, so well, like better than anyone else. And that makes them a particular challenge because they're going to see right through you.
Oh yeah. Yeah. They're extremely smart. That's one of the other stigmas that you think that, and people say, oh, they're just like, they don't know anything, but they're extremely smart. They know their rights. They know that you can't force yourself as far as to do a chemical restraint if there is no reason for it, those kinds of things. So yeah, that's a good point. I agree with you 100%.
Yeah. And one of the things I always tell people is they'll read you well, they'll have you nailed.
Yeah,
And
that's for sure.
and because one of the things that I think I don't think all nurses realize is, like, for us, it's a skill we develop in the emergency department. But for a lot of these patients, it's a matter of survival. If you're kind of annoying, if you're sitting there going, okay, if you're self-aware enough to know that you're a little bit annoying, and I know I'm hanging out with Aaron, and I know Aaron maybe isn't as a well-adjusted human being as maybe me, and I know that he's gonna punch me in the face if I get on his nerves. I need to be able to read that. And I think, that's what makes these psych patients so good at reading. It's survival for them.
Right. Right.
And they know if they know if you're kind, they know if you're not kind, they know if you're easily angered, and they'll touch that last nerve if you show it. So
A lot of these patients have it's been like a revolving thing. It's kind of rare that you're going to come across, oh, this is their first time. You know what I mean? So they've been around this type of environment, going back to the frequent flyer type of thing for whatever reason that whether they end up in the ED. But a lot of them, they'll get to know you because they're there so often or whatever. So
yeah, I remember frequent flyers all the time being like, "Hey, Kevin, how you doing, buddy?"
yeah, yeah, that's true. Okay.
Now, one of the things I know you have a particular passion for, and is such an important skill to be able to deal with in the emergency department, is talking about suicidal patients and suicidal screening. And I know that's a little bit of a passion project for you and passionate topic for you. But one of the things I think a lot of ER nurses have a really tough time with is doing suicide screening on patients who are coming into the emergency department and doing the screening and then kind of knowing one, do not every ER has a suicide screening tool. So we can talk a little bit about that. But how do, how do you know whether or not the patient's like truly suicidal?
That's an excellent question. So most electronic health records, most EMRs or EHRs, they have different screening, like different suicide screenings, right? And as far as like billing purposes and stuff like that, so most of them will require you to do it. One of the things that I've seen, and again, I'm speaking, so I do frequent visits to our hospitals in the Rio Grande Valley. So I can tell you that I've been there and I've seen them triage and stuff like that. A lot of them will bypass the suicide though, or they'll be brief in how they ask the question. So first of all, suicide is a big taboo, right? And it is not just in the Rio Grande Valley, but it is. Nobody wants to talk about the S word. It's a bad word, right? But it's one of those things that nobody believes in. It goes happens, it happens, kind of thing. But I think that we need to normalize and standardize that it's part of our assessment with every patient that we have. We need to ask. Doesn't matter. So if you look at guidelines, if you look at recommendations about which screening tool is better than the other, they're all good. There's a reason why they exist, right? The specificity, the validity of these tools is there. So they all work. It's all about how you use it and how you implement it. So a lot of these tools are not going to tell you if that person it's not going to diagnose this person, oh, this person's having SI or whatever. But it will tell you that this person is like, it'll give you the red flags, right? If you look at the questions that they ask and how specific they are. And that's an advantage for us. That's a win for us because then we can follow up with the individual. And as far as, okay, what is it that we need? Is it someone that, and you have times where you have a screening that will reflect someone that is very suicidal or having suicidal thoughts, but then they're like, they don't have a plan or those kinds of things. But it doesn't matter, but you're still having that conversation and you're able to provide that support to that individual and help direct them in the right direction as far as who's going to be able to help them out and, what the next step in the process should be. But we have to normalize that. Like whatever, I'm not going to tell you this screen tool is better than the other or whatever. All I'm going to tell you is follow up with your institution, with your hospital. What do you have in your medical record or your EHR, I'm sorry, and make it a practice. Make it a practice. Ask those questions. We don't want to ask why, because what's going to happen, and it's the same thing with every screening tool. You're going to have your false positives, and that's okay. That's okay. But you'll have that conversation. You can provide education, provide resources, the suicide hotline, those kinds of things. But we need to normalize that. We need to make that a part of our standard practice.
I think oftentimes one of the things I see probably more than anything else is nurses ask the question and they almost imply that the answer is no, right? Like they're like, but you're not suicidal, are you? Or they'll be
Yeah.
like, any thought, yeah, she's, I guess, got to ask these questions. Any thoughts of suicide? Probably not, right? And they almost ask like, here, this is where you tell me no,
Yeah,
instead of
that's a
saying
good
like,
point.
tell me what you really feel.
Yeah, I agree. I agree. I had a really interesting experience a couple of months ago. I see a lot of veterans and they had an event and they invited me to the event, right? So there was a lot of folks there, right? And I was just listening to, so obviously I couldn't go up to them because I'm the provider and say hello or whatever, but I was listening to them and one of them was like, you know what? I'm always suicidal. I'm always suicidal. And again, I'm a provider, right? So I didn't say anything. So I'm just listening. He said, but you know why I don't tell you? Because if I tell you that I'm suicidal, the first thing you're going to want to do is you're going to want to admit me to a facility. That's an excellent point, right? So that was another one of those experiences that I was like, wow, that's pretty bad. And it's the same for all, and that's me that I deal with folks that have these types of issues. So can you imagine someone who doesn't, and you hear someone say that I'm suicidal, you're going to freak out and you're going to panic, right? So that doesn't mean that he's going to go and hurt himself right then and there, right? But these
Yeah.
are the thoughts that they're having. And that's where we have to change our attitude with these folks. And I'm not saying you have to be a psych nurse or a psych nurse practitioner or psychiatrist or anything like that, but do your due diligence when you're going over these screening questions, ask them. And if it's something that it comes out being positive, and follow through with it. Get your
Yeah.
social worker involved, case management, contact tropical, contact screening services, have them thoroughly screened. And if it's something that they need to get admitted, well, they have to get admitted for if it's to that extent, or most of the time it won't be. Most of the time they'll provide them with resources, guidance, and because a lot of times these folks may not know that. So that's where, and there's a lot of folks that will have, the suicide is one that's very different than that, because there's folks that will have an episodic, they'll have something that happened that made them feel that way. You know what I mean?
Yeah.
Versus someone who has a diagnosis of bipolar, schizophrenia, or whatever. But that's one that we definitely have to be very aggressive in our approach. We really have to screen. We really have to ask these questions that are sensitive and difficult to answer for many, and not be judgmental. That's the worst thing we can do.
Yeah. Now, speaking of judgmental, and I'm going to ask this question. I have screened patients, many of patients that I say, "Hey, are you suicidal?" And they're like, "Yeah, I am." And I'm sitting there going, "I don't think you are." And just, for whatever reason, like I think to myself, certainly you have psych issues going on. Certainly, I mean, there's been places like, I'm like, okay, you're not suicidal. You just want a place to sleep for tonight. And you're going to say you're suicidal to get that. Now, I know that that is beyond my capability to make that call and say, because I've been dead ass wrong before. But how do you handle that when you have a patient who is maybe screening for suicidal and you're like, but are you really? And I don't know if that's beyond the ER scope. And I think it probably is, but like, how do we handle that? How do we handle that? And again, you just tell me if this is something we can keep in the episode or not. But I think it's a valid question that I think a lot of ER nurses probably feel.
Right, right. No, and so that is a very valid question. That's a difficult one to answer, especially because we've all had those cases where we're like, oh, it won't happen. And like I said, until it happens. And then we're like, oh shit, you know what? I should have done this, or I should have done that, but it's too late. You know what I mean? It's too late for that. Should have, or I could have. That's a difficult one. And to be very honest with you, I wouldn't put that on my, I wouldn't want to encourage anyone to make that decision until they're
Yeah.
evaluated by an expert in that area. You know what I mean?
Yeah.
And if that's the case, if they're doing it because they want attention, or if they're doing it just because, like you said, they want to just to kind of have a place to stay, I would much rather, I would much rather them have that. And I know for those of us that are EDs, well, they're going to take up space or whatever. I get that part. But to be honest with you, I think that's a difficult one. And it's, especially I've had a lot of situations where they follow through with that. You know what I mean? So that's a tough one. That's a tough one.
Yeah.
It's a good question though. And I can see how many of us have that question in the back of our head, but that's a difficult one to answer.
Yeah. That's what I figured. And I always, make the assumption if they say yes, then it's yes. And
Yeah. And I get asked this a lot. So my area of practice, so I do a lot of research and work with children. And the publication that we had was on EMS and behavioral issues with kids. And how do you know? How do you know? And maybe I think what your response for an adult, I wouldn't take that lightly. If they're telling you they're suicidal and stuff like that for an adult, if it's a child, that changes, right? Because maybe they don't have the resources, or there are certain gaps. But at the end of the day, I wouldn't take, when somebody tells me that they're suicidal, I'll follow up all this has, and I don't take that lightly, because I've had the folks follow through with it. You know what I mean? So that's one. If it's gonna happen, it's gonna happen, right? But if I can at all have any part and prevent it from happening, I will do my very best.
Yeah.
To keep it from happening.
yeah. So I think that's all the questions I have for you, my friend.
Okay.
This has been a lot of fun. It's been a good episode. Interesting stuff. And yeah, I like psych patients. Psych patients are ones I don't mind taking care of. I mean, sometimes they can be a challenge, but
They
overall,
can.
overall, I think they need care too.
That's right. That's right. They do. They do. And it's one of those things that I enjoy what I do. I'm always having to be on my toes. There's things that I can't disregard anything. You know what I mean? And things have gone well. I have a lot of challenges at times with patients, but we work together, and it's, when you see them doing better, you see them improve, it's pretty neat.
Thank you. Thank you so much for doing this with me. I really appreciate it.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.